Colleagues, I would like to welcome you to our Learning Lab on COVID-19, marginalized populations, and health disparities. As we continue to confront the evolving COVID-19 pandemic, we increasingly see the epidemic is highlighting and exacerbating long-standing health disparities. We see the disproportionate impact of the disease on marginalized and vulnerable populations. Those disparities and the affected populations are the topic of our symposium today. You will note that this is part one of a two-part learning lab. The second part will focus on what we can do to address these disparities and promote health equity. This learning lab will build on the information provided in the March 27th symposium. The recording of that event is available on the Clinical Public Health webpage. Our agenda today will be as published in the announcement. There will be an opportunity for questions after each presentation. To submit a question, please use the Q&A section to the right of your screen. Send your questions to me, Carla Bartholomew, using the drop-down arrow. You can type in your question at any point during the presentation. Simply click and send. All attendees are in listen mode. You may join at any point, and you may attend any and all portions of the symposium. If you're disconnected at any point, please rejoin the event. This symposium is being recorded, and the link will be posted after the event, again on our Clinical Public Health webpage. The events and our knowledge base are evolving quickly, so the information presented today is current as of today, but may change in the future. We encourage you to stay up to date via the Himmelfarb website listed here. And with that, I'd like to introduce our first presenter, Dr. Hannah Axelrod, to provide an update on COVID-19 in the U.S. and its impact on key vulnerable populations.
Dr. Bartholomew. I am sharing my slides right now, and thank you everybody for joining us today for the second Learning Lab on COVID-19. I will start with an update on some of the key areas in which on which we focused in the first Learning Lab, and then we will transition to talking and discussing about vulnerable populations in more specifics. I, as before, have no financial conflicts of interest. I will again be sharing some information that is in preprint form or investigational status. And I am sharing this photo of a bobcat from Yosemite National Park, where I was previously planning to be camping later this month. However, due to the COVID-19 related shutdown, nobody is camping in the park, and the rangers have been posting pictures of the wildlife enjoying their human-free space. This is the only part of this presentation that focuses on animal health. The rest of today will be about humans. This is the latest shot of the Johns Hopkins dashboard on global spread of COVID-19. Since we last talked about it in our previous lab, the focus of the pandemic has shifted out of Asia into Europe and then fully into North America. You will notice also growing circles representing positive populations in South America, countries in Africa, Russia, and Central Asia. Some of the reporting is limited by availability of testing and also by what the countries are willing to share about their internal numbers. Based on the available numbers, it does seem that some countries have turned the corner in terms of reducing new cases. Most notably, China has been reporting for a month now that its epidemic is under control. Countries in Europe that were hit by the epidemic really heavily a month ago, Italy, Spain, France, and Germany have seen a decline in cases since implementation of lockdowns and nationwide responses. There are countries that implemented those measures really early on, including Australia and New Zealand and Norway, which saw even faster reductions in their cases. The United States is an outlier on this graph, both in the lack of a nationwide lockdown or shutdown order, and in that our new cases are still steadily holding steady rather than declining. We are currently responsible for about 1/3 of global daily deaths. This is every day, and that's in the neighborhood of 1,800 to 2,000 US deaths per day. The curve did seem to at least stop going up exponentially when looking at the country as a whole. Now, what this really translates to is a lot of local curves overlapping with each other. So this is from the Johns Hopkins dashboard. They now have a section representing cases and deaths adjusted and unadjusted by population, as well as some measures of how the epidemic is evolving in different parts of the country. Key features over the past month include a shift out of the most dramatically hit areas early on, such as California, the Seattle area, Boston, New York, and spread towards smaller centers of population across more of the country. That said, most states are still seeing increasing numbers of cases each day or on a weekly basis. Some are holding steady, including now New York, and cases are decreasing in areas where population is low and also where measures may have been implemented. In the DC, Maryland, and Virginia area, we are now up to, I believe today it's 199 deaths and close to 4,000 cases. We are surrounded on both sides by states where there is still ongoing active transmission. There are orders in place restricting public gatherings, business activity, and recommending people distance themselves at home and observe personal and family precautions. And the Bowser administration has extended DC's protective orders until at least mid-May, likely longer. This is from the mayor's update briefing last week. It is a slide showing incidents by ward, as well as a breakdown by race and ethnicity in the District of Columbia. The most dramatic finding on this slide is that African Americans are about half of the population of DC and represent about half the cases we're seeing. However, the mortality rate is higher, and they represent the hardest hit group in DC in terms of mortality, with 81% of deaths so far. We want to think about this as we go into the rest of the discussion today and the presentations that will follow mine. This is a map of the region adjusted by population. So you want to remember that we're not in a bubble. There is no possibility of a wall around the District of Columbia. We really have to think about transmission on a regional level. There is a graph out in just the last couple of days showing for the first time the number of excess deaths, that is, the number of deaths in different regions that are above historical levels. So compared to 1 year ago and the average over a 10-year period before that, the United States has seen a dramatic increase of about 6% rise in deaths nationwide. I'm sorry about the noise disturbance, that was a cat. The excess deaths figures are paralleling what we see around the world in other urban areas. Every time I show you a graph, I want you to ask what the y-axis represents. So those are all on different scales on the y-axis, but the shapes of the curves are illustrated. And this is a breakdown in the Washington Post in a investigation done jointly with the Yale School of Public Health, in which they looked at the reporting of the excess deaths and causes of mortality, showing in different states and in New York City what proportion of the excess deaths is reported as COVID-19 deaths. You'll see that depending on where you are, there are dramatic undercounts or dramatic differences between how many more people have died since the COVID-19 epidemic hit this area versus what is directly reported on the death certificate. I'll spend a minute on this. Reporting requirements and reporting recommendations are released by the CDC. However, physicians and medical examiners filling out death reports and death certificates may differ in their practices. There may be differences also in who is dying in what phase of the epidemic. While early on there was a probably more direct relationship of excess deaths to the spread of the virus, there were more difficulties in obtaining timely tests, and people might have passed away before a test was completed or could even be sent. Different areas were responding differently in who qualified for testing, depending on the availability of tests. Additionally, as the epidemic evolved and parts of the healthcare system were affected, there have been delays to medical care for other conditions. People might have a hard time obtaining routine and preventive care these days if the medical practice on which they were depending, such as a neighborhood health center or a private practice office, had to shut down their operations. People may also be reluctant to seek medical care for emergency conditions, such as symptoms of a heart attack or stroke. And this has been a real concern, both on the emergency management and emergency medicine level, and on the level of healthcare management and policy making, because we need to balance the drive to prevent exposures and possible transmission in medical settings against the harm to people from delaying care or being unable to access it. So a few updates on pathophysiology since 1 month ago. We are learning more about what COVID-19 SARS coronavirus 2 actually does in our respiratory system. The initial reports were consistent with a picture of ARDS, acute respiratory distress syndrome, which is a combination of direct viral damage, but then transitioning to a cytokine and inflammatory inflicted injury. That still remains the frame to some extent. However, the pulmonary and critical care experience has been that the lungs of patients with COVID-19 in its severe presentations in many ways behave differently than the lungs of patients with ARDS, and that this picture evolves over the course of the infection. The key features seem to be people present with silent hypoxia. They may not realize it, but their blood oxygen saturation is 70%, 50%, and they may not be seeking care early enough to prevent extreme stress and underoxygenation. They might be working very hard to breathe, causing further ventilatory damage on the microarchitecture level. In early and more mild disease, there is direct viral damage to the respiratory system and hypoxia, but the lung compliance and architecture remain more or less intact. And these patients do well with non-invasive oxygenation, such as high-flow nasal cannula. They do well with positioning in a prone position, which helps recruit parts of the lung that would otherwise be underutilized and use the shunting effect to benefit. In more advanced disease, there is more inflammatory damage. The lung gets heavier, denser, more of a classic ARDS picture. But these patients require mechanical ventilation with increasing levels of positive end expiratory pressure support. Intubated patients continue to have extremely high mortality from COVID-19. There has been a shift in management in which we try to avoid intubating patients early and give them a chance to recruit more lung and recover with other maneuvers. The vascular and inflammatory aspects of COVID-19 are really emerging as the key feature of advanced and severe disease. So in addition to a generalized cytokine storm and all over inflammatory response, there appears to be something specific going on in the endothelium, both due to direct viral invasion from binding to the ACE2 inhibitor, and also from the consequences of inflammatory damage. And then inside blood vessels, the alterations result in a procoagulopathic process, so that these patients have an unusually high incidence of thromboembolic and thrombotic events, venous thromboembolism, possibly pulmonary embolism, although it is hard to obtain good imaging on advanced COVID-19 patients, and cardiac events and stroke. The vascular inflammation and thrombosis are understood now to play a larger role in these, and patients with severe COVID-19 may receive, if there are no contraindications to it, may receive therapeutic anticoagulation. Preventive or prophylactic anticoagulation is important for people who are admitted to the hospital with COVID-19, but who are not yet in the severe stage. There has been a question all along about whether the involvement of the ACE2 receptor in COVID-19 infection might mean that patients who take ACE inhibitors or ARBs would be at either a higher or a lower risk from this disease. There is a somewhat complex relationship, as illustrated in this JAMA Cardiology paper, between patient age, ACE2 receptor expression, the activation of the renin-angiotensin system, and the effect of SARS coronavirus 2. The overall takeaway is that if your patient is already on chronic ACE inhibitor or ARB therapy, when they're sick is not the time to stop it, because it is not the right time for them to go into a hypertensive emergency or decompensation of heart failure. The medication is overall beneficial, and any negative effects on the course of the disease are balanced out by the role of the same mechanism in inflammation and in blood pressure control. There are numerous other manifestations of COVID-19 that are appreciated now. Larger numbers of people have acquired the disease, been treated, and lived through it. So GI involvement is more appreciated now, may be present in 5 to 15% of cases. There may be some regional differences, both based on what strains of the virus are circulating and cultural differences in how people express symptoms, as well as the age of the patients. For instance, children may present with more diarrhea predominant disease than adults. The GI involvement is also a problem in nursing homes and in elder care, because it exposes the people caring for older adults who are incontinent and may need changing to higher levels of the virus. There are registries for dermatologic symptoms for the disease course of patients with HIV, for patients with cancer and rheumatologic disease. We encourage everyone to check out those registries and patient advocacy groups. There's also ongoing investigation on what exactly does this virus do in the brain and in the CNS. There is some evidence for immune-mediated damage, such as Guillain-Barré syndrome, some possible involvement with neurotropism and effect on the respiratory drive centers, and growing number of reports of stroke because of the coagulopathy issues. There is an interesting study I'm sharing from the American Society of Microbiology, a journal of virology, which looks at HLA differences in world populations, as well as HLA allele associations with the ability of the immune system to present different parts of coronaviruses for immune recognition and formation of immune memory. What this study addresses is that there are different parts of the SARS coronavirus 2 peptides which may be presented based on which HLA allele you have. If you have HLA B4601, that people with that allele tend to present fewer of the peptides for the virus and may be limited in their ability to form a lasting immune response to it. People with the alleles outlined in green, on the other hand, tend to preserve and present highly conserved portions of the virus for immune recognition and might stand a stronger chance of forming a lasting immunity. This is all very speculative right now. It's based on genome-wide association studies and experiences, for the most part, with other coronaviruses. But this has to inform some of the discussions around vaccine development and around the question of, is there lasting immunity from this virus or not? It is hard to predict how those HLA variations play out on a large scale in a heterogeneous, diverse population, such as in the United States or in Brazil, which are the two of the emerging centers of the pandemic right now. The treatment updates, this broadly speaking, are still the categories of therapeutic approaches. We talked last time about the possibility of using anti-inflammatory or existing drugs to interfere with endocytosis or inflammation, the possibility of blocking viral replication using a directly acting antiviral medication, such as a protease inhibitor or an RNase inhibitor. The inhibition of the inflammatory cascade with immunomodulatory blockers. Most of the advances up to this point have honestly been in supportive and critical care and what we do to improve these patients' chances of healing from the disease. Passive immunity with convalescent plasma has ongoing enrollment and an ambitious nationwide program run by the American Red Cross and the Mayo Clinic, in which we are participating in GW. And active immunity through vaccine development is still a long way away. An update on hydroxychloroquine. Since it was first publicized over a month ago as a potentially very promising way to reduce viral shedding, time to improvement, and other kind of intermediate or surrogate markers of disease. Since then, the society that published the most promising of these studies actually issued a statement that the study did not meet its standards for publication and was overhyped. In about the same time, even though France was one of the countries that early on was very much in support of hydroxychloroquine treatment, due to emerging information about lack of improvement in patients on it, as well as major cardiac risks to the ones receiving high-dose hydroxychloroquine or chloroquine, there have now, for almost a month, there have been hospitals that kind of reversed that momentum. So this is several articles in a preprint that are at various stages of progressing to full publication, showing lackluster results, or in the case of the VA study, actually worse results with hydroxychloroquine as opposed to the control arm receiving standard of care. These are, for the most part, either small studies or open label studies, which are not blinded. However, between these and several other papers coming out from all over the world showing that there may be more risks with chloroquine and hydroxychloroquine than accounted for, the medication is no longer enjoying the same spotlight it was a month ago. In addition, the American Heart Association, American College of Cardiology, and Heart Rhythm Society have issued statements in recognition of the risks of physicians adopting medications that have not been properly vetted or gone through full randomized clinical trials, and issuing interim guidance on how to at least avoid harm from these medications by addressing the QT prolongation and arrhythmia generation potential. All of this put together is, at the very least, a lesson in how much caution we should use when trusting information that's not fully peer-reviewed or even already published, but with weak study design, small numbers of patients tested, or issues with consistency in results. While we have to keep abreast of new developments and be actively engaged in the discussion around COVID-19, all of us are learning how to balance trying to innovate when we are desperate for new treatments with preventing patient harm and also preventing the degradation and deterioration of our own standards for what is evidence-based medicine and how we should practice as thoughtful clinicians. So to go back to medications that are in trial stages and for which the evidence is based on small numbers, remdesivir, the antiviral medication that was initially developed for Ebola and has been translated into compassionate use or clinical trial use with SARS coronavirus 2, shows some positive effect on oxygenation requirements in the study of a small number of patients with severe disease. And this effect was consistent in patients of different ages, although it did not fully reverse the trend towards higher mortality among older patients. That said, this study involved rather few patients, and there are ongoing clinical trials for which there have been rumors of either promising or not promising results, depending on which day of the week and which news outlet you're listening to. So again, we're withholding judgment. We're offering at GW remdesivir on a compassionate or expanded access basis, but we have a thoughtful discussion with the patient or their surrogate decision maker about recognizing that this is not a proven treatment. We don't know if it works. We don't know if we know all of its side effects yet. And we make a shared decision together. Convalescent plasma is more or less in the same situation. We have evidence from rather small numbers of patients treated with it. So this is immunoglobulin in the form of plasma collected from patients who have recovered from COVID-19. The donors are typically at least 2 weeks out from any symptoms or from last testing negative for COVID-19. And the recipients typically have severe disease. The patients in this small 5-patient report all had improvement, although you'll notice in table 2, 2 of the 5 patients were still hospitalized at the time of publication. There is an ambitious program across the US, as I mentioned, supported by the American Red Cross, and for which the data management and the institutional review are provided by the Mayo Clinic. There are also more specific trials in individual medical centers, including in New York City and in Baltimore. So we look forward to seeing how this treatment plays out in patients in the studies. The National Institutes of Health have an excellent treatment guide up on their website, and I don't often refer to very long guidance documents as excellent, but this one truly is. It's easy to navigate, it is constantly updated, and it provides both summary information and more detailed tables of evidence. I call your attention to their statement that no drug has been proven to be safe and effective for treating COVID-19 at this time. They make recommendations concerning whether certain treatments such as remdesivir, hydroxychloroquine, and convalescent plasma, or IL-6 inhibitors such as tocilizumab can be offered on a compassionate use versus in clinical trials only. And that information may change week to week depending on results of trials coming out. They do also provide guidance on how to manage everything else but the virus or around the virus. So they support the Cardiac Society's recommendation of continuing the ACE inhibitors or ARBs, but not starting them if your patient's not already on them. Statins, same story. There is some possibility that statins can mediate inflammation on a systemic level and kind of tamp it down. So if your patient's already on a statin, there is good evidence for continuing it. However, it's not a medication that's ever been proven to make a difference if you start it acutely for someone who is in the middle of a severe viral infection. Corticosteroids, whether or not to use them depends on the clinical status of your patient and whether they have other indications for it, such as asthma. And nonsteroidal anti-inflammatories, there were initially reports, mostly out of Europe, that ibuprofen should be avoided in favor of acetaminophen. However, this was not borne out by evidence, and the current recommendation is that it doesn't matter which anti-inflammatory or antipyretic you use to manage fever, muscle aches, and other symptoms of COVID-19. With that, there is a word of caution around the NSAIDs, which is in patients with chronic kidney disease who are already at higher risk for mortality from COVID-19. You want to reduce potentially nephrotoxic drugs. This is a diagram from The Lancet showing the current numbers of registered clinical trials that are looking either at the standard of care versus any of these interventions, or the standard of care versus some combination of these interventions, or just different arms of interventions. This diagram is guaranteed to only grow more complex by the week. And this gets me to my next slide, which is in the words of Paul Sachs, who is one of the luminaries of the HIV field at Brigham and Women's. He writes a rather informative and occasionally snarky blog called HIV and AD Observations. And in talking with a reporter who routinely covers medical news and is quite versed in the terminology, the reporter commented that it's, to use a cliche, which reporters shouldn't, but it's like drinking from a fire hose trying to cover all the COVID-19 research news these days. But Paul Sachs thinks it's more like trying to drink from the Niagara Falls. There is a very real struggle on the part of medical professionals to communicate unclear, contradictory, and preliminary findings. And sometimes people who are outside of the medical field struggle with it even more, which is understandable. We want to be responsive to the requests of the lay media and of our patients and family members to discuss new information that they're very excited about or that they're very scared by, depending on the week. But we have to take it all back to this idea of evidence-based practice and preserving equanimity until there is really definitive scientific evidence that's consistent, ideally across more than one research setting. How to communicate all that effectively. So it's a work in progress for all of us. I really like this book by Alan Alda, the actor from MASH and The West Wing, who has sort of a second or third career in science communication. He trains scientists to talk to non-scientists about science. He has some very informative and entertaining videos, and did a talk at GW a couple of years ago, in which his main message was that it's really not about statistics. It's about relating. It's about finding some kind of emotional or intuitive aspect to what you're trying to get across. And that may differ on who your audience is and how well you understand them. But if you can get a sense of what their values are, what their anxieties are, you'll be in a better shape to communicate even very complex scientific information. He recommends doing improv acting as a way to improve these skills, which I wish we had that kind of time. But I think all of us during our medical training essentially learn some of these skills in communicating incomplete information and managing margins of error and uncertainty. Some challenges on the health system level. We continue to work with imperfect tests. So the mainstay of detection in acute infection is PCR nucleic acid amplification tests, which have been now spread from state labs and picked up by academic and commercial labs and are now much more widely available. That doesn't mean they're universally available, and many locations still struggle with back orders of reagents or human staffing, which limits how many tests can be run. Not all hospitals have point of care testing or on-site tests. Some, especially small ones, or hospitals in more rural locations, may rely on state medical labs. Others may have purchased rapid point of care diagnostic tests that are potentially less accurate than the more labor intensive PCR methods that were initially validated. And there is an emerging field of antibody testing for COVID-19, which has issues both with sensitivity. So if you test too early in the course of the disease, then your patient may not have generated IgM, never mind IgG. If you test too late in the disease, you may pick up some IgG, but there are also specificity issues with cross reactions with antibodies against the community circulating coronaviruses. Remember, we have 4 other seasonal coronaviruses, and we are still well within the time of year when they occur, especially in different parts of the country. And then there is the question of, do antibody levels, if you detect IgG and you're certain for sure it is specific, you have a lot of faith in your test, and it's IgG to SARS coronavirus 2, well, what does that predict in terms of long-lasting immunity? So that takes me back to the HLA paper. We may not know exactly which viral peptide that antibody was formed against. We may not know what it means. We also are still learning about how much the virus mutates as it circles the globe and then again. So we have a lot of scientific blank spots on the map right now. Some reports on the clinical performance of the PCR tests. So this is a report of 20 patients in which different bodily fluids and sites were sampled. And pharyngeal swabs, which are the mainstay of where you test, as well as the sputum, did correlate with nasal swabs and with overall levels of virus. However, you'll notice patients 10 and 11. Patient 10 had viral presence in their stool, but not in their pharyngeal swab or in their sputum. And patient 11 didn't have either pharyngeal or stool presence of the virus. However, it was found in sputum. So depending on where you're testing and what point of the clinical course of the patient, it is possible that PCR testing will miss about 10% of cases. So in other testing news, some issues with tests that are released widely and adopted widely, including by people who are not infectious disease experts. All of the tests that are being rapidly released are released under the FDA's emergency use authorization, which means that they submit the validation data that they've done internally, but they haven't submitted for federal review or peer review any results of large-scale field testing. So we'll have to see how their tests play out in the general population. And this is particularly true of the antibody tests because the sensitivity and specificity of those are more variable to begin with. So the World Health Organization specifically stated last week that given all the issues with antibody testing and that we don't know if their results truly predict immunity, governments should not, for instance, start issuing immunity passports or permits to travel based on the results of an antibody test at this time. So speaking of government reports, the CDC Morbidity and Mortality Weekly Report about 3 weeks back released a detailed summary of risk for severe disease and death in patients in the US with COVID-19. And this diagram particularly stands out, this graph, because it shows very high risk for ICU admission in patients with chronic kidney disease and cardiovascular disease, as well as diabetes. So these are, for many patients, those are conditions that are co-occurring and the management of which overlaps. In the immunocompromised group, not all immunocompromised people really have anything like the same disease, right? They may have neutropenia from chemotherapy, or they may have well-controlled HIV with a CD4 count of over 500 and essentially healthy cellular immunity. But we have small numbers in national registries up to this point and are going to be able to comment more about which immunocompromising conditions or specific immunomodulatory drugs can be harmful, or whether any of these patients might be protected against severe disease. Their inflammatory cascade is coincidentally blocked at the exact right point. Chronic lung disease, which overlaps with smoking, but also occupational exposures, is also a strong predictor of need for ICU care. And I remember, depending on your age and where you are in the country and what the ICU admission practices are, the mortality rates for people who were admitted to the ICU and were put on a mechanical ventilator are quite high. In New York, over 75% of adults admitted to an ICU for mechanical ventilation died. And if looking at patients over 80, the mortality rate was 97% if they required mechanical ventilation. So why do I have a heart disease map here? This is from a couple of years ago. This is way before anyone except maybe a couple of virologists who study bats ever thought of COVID-19. So this is a CDC map of our heart disease death rates, and it probably overlaps very closely with where high incidence of stroke, obesity, diabetes, and chronic kidney disease are, due to the same epidemiologic and partially shared physiologic factors that contribute to these conditions. So this is essentially where, if you're looking at a population area that's hit by COVID-19, where people would have, based on the MWR report, the highest risk for severe disease and mortality. And this is the CDC's Social Vulnerability Index, which combines indicators like education, distance to healthcare, economic status and income, to show where the economically vulnerable counties are. So put together, those you might ask, why am I showing you the same map over and over? And that's precisely the point. So what do we mean by vulnerability? We may have a different interpretation of that word in medicine and medical science than people in the social sciences. And there's been a lot of work over the last 20 years to try and bring those understandings closer together. You know, who is vulnerable? Is it patients with HIV AIDS as represented by the AIDS quilt? Is it older people? I have an example of Dr. Tony Fauci here, who is not only the most recognizable physician in the country, but also a man over 70. And is it, as the Surgeon General mentioned a few weeks ago, is it people in particular racial and ethnic groups, for instance, as we're very much and increasingly aware, why are we seeing the rates of infection and mortality among African Americans and Hispanics that we are seeing. So to borrow the title of the PPS course that many of you have taken, it is a question of people, populations, and systems. And there are issues with resources for detecting and for treating COVID-19, as well as the policies. So lack of consistencies in policies on the state versus federal level, competing entities, missing leadership or occasionally counterproductive actions by leadership, all play a part. However, this is all occurring within a greater context of a history of racial injustice, lack of access, and lack of safety net or deteriorated or dismantled safety net for many of our patients. We also have to think about specific settings in which the consequences of transmission might be worse, or the tools available for reducing transmission are less, such as incarceration systems and nursing homes. And the map on the previous slide, by the way, was the income map of DC. So when we talk about vulnerable populations, as a physician and epidemiologist, I think about these 4 questions. Who is at the greatest risk for acquiring the disease? Who has the greatest number of exposures with the least protection? Who out of the people who acquire it will progress to have more severe disease? Are there underlying medical conditions that predispose to worse outcomes? If the people that we know are at risk for severe disease are unlucky enough to get sick, what barriers do they see to seeking optimal care and receiving it? And then when we are tallying our cases and deaths and deciding where resources go, who is counted and are those numbers acted upon? So to set aside the question of inherent biological difference, there's absolutely no evidence that different ethnic or racial groups have a different process when they're infected with SARS coronavirus 2. We all have the same virus, we have the same receptors. There's no evidence for, let's say, a different concentration of the receptor in tissue based on genetics that we know of right now. However, there is a difference in the concentration of that receptor based on age, as we discussed. And there might be some difference in immune response, but it in no way accounts for what we're seeing play out in the US right now. There are much more dramatic and obvious explanations for what we're seeing, which is that people who live in urban centers with highly concentrated areas that have been populated differently according to different laws and practices over time, have different levels of economic hardship and limited ability to self-isolate if people are living in small apartments or multifamily households, people who work in essential jobs or caregiver jobs, and people who already face discrimination and structural barriers to achieving good health. This is before we even get to the unequally distributed concentration of chronic medical conditions in our country. And when we talk about discrimination, there is medical evidence that it contributes not only to people's ability to access testing and timely care, but also might contribute to a higher lifetime risk of cardiovascular conditions through the stress and inflammation axis, which is beyond the scope of the few minutes I have right now, but it might be that structural and systemic discrimination and stress actually might impair people's ability to respond to new physiologic challenges. Stress from COVID-19 is also experienced differently in different segments of the population. There are surveys right now saying that if you're Hispanic or Black, you have a higher chance that you know someone who's been affected by COVID-19, and that you might worry more about your ability to get good care if you become sick or someone in your family does. So there is more time to talk about the data in one of my colleagues' presentation later, but right now I'll just mention that not all states even report race-specific data on confirmed cases, deaths, or availability of testing. The big issue of environmental justice is something that really jumped out at me from reading in the last couple of weeks. So there is a historic trend of people with the least amount of decision-making power and financial resources being kind of pushed to the least healthy neighborhoods of cities or of rural areas that might have exposures to environmental and industrial pathogens. So parts of large cities, but also parts of the American Southeast, where historically people have been exposed to higher levels of air pollution, might have higher rates of underlying lung disease. Industrial pollution may correlate with higher rates of cancer, especially in young people. And these people are all at risk for worse outcomes should they get coronavirus infection. If you would like to read an 800-page account of how specifically New York came to look the way it did, there is a fantastic book called The Power Broker, essentially describing urban renewal and changes in urban planning and redlining throughout the 20th century. So, some of the, speaking of New York, so this was an interview in the New Yorker with a former classmate of mine, Rachel Bedard, who is a geriatrician who works on Rikers Island, the city jail of New York City. And she, in March, was advocating for getting patients released to reduce the likelihood of infection spreading through the jail and of people coming to fatal outcomes from it. Essentially, she's someone who cares for an aging population in jails and prisons. And these are the people who absolutely cannot self-isolate and who have many of the same medical comorbidities. So to keep them together, essentially cause the predictable setup for a bad outbreak. The bad outbreak has since then definitely occurred. There were over hundreds of cases within the facility itself and then far beyond. And the findings of that outbreak in summary are published in JAMA Internal Medicine yesterday. But my classmate herself actually became sick while working in this environment. And similarly, people who live in nursing homes and people who care for elders are a vulnerable population. Again, because of the lack of possibility of meaningful social distance and the extreme medical vulnerability of the people involved. So there are very alarming reports from across the country of the high mortality rates in nursing homes. I will leave us on a positive note about, well, what did we do in the past when faced with an epidemic for which we did not have a medical treatment, for which we had to devise a prevention strategy in the process of learning more about it? And how
Dr. Axelrod, this is Carla. This has been just a great overview, and we really appreciate the entree. We have one or two questions as we begin to transition to Dr. Kendig. We were wondering, so that we can get to that question or two, if we could maybe transition to the questions right now and then move on to talking about incarcerated populations.
That is perfect. And I'm sorry, Carla, I just saw your text. This is in fact the slide I was planning to leave you with.
Great.
In which we win in the long run by listening to our patients, understanding their risks, and allying to get the resources that we need to the people that need them the most.
It's a great way to frame future and how we continue to progress with COVID-19. And we do have a question about how, first of all, to the point of science communication, how we tend to use race as a risk factor, and then what GW specifically is doing to address some of the racial disparities that we see not just in patients but beyond. And we'll begin to transition to Dr. Kendig as you finish that.
Oh, this is just the perfect question. So I was hoping someone would ask that, so I can put this up. So in addition to, in addition to continuing to provide good medical care for all of our patients and learning how to meet the needs of our patients in a culturally sensitive and appropriate way, we are working across GW to expand testing on the city level. So we've opened the drive-through sites in the testing tent. We are working together with different schools within GW, including this is a picture of an engineer from the School of Engineering working on a 3D printed mask to help protect our healthcare workers. So I don't have numbers of what proportion of our medical staff and ancillary staff, or nurses, or aides, everyone who works in the hospital. We have a very diverse staff and medical employee population, and we need to protect them and their families first. We've expanded telemedicine, which is something a few of us in HIV have wanted to do for a while, recognizing that transportation costs are a major barrier to care for some of our patients. Even though this was not the way we planned to roll it out, we now are able to improve access by doing televisits. And then there's a fantastic guide put together by the medical students that I'm featuring here by Herlene Marwa's group that I encourage people to look into in more detail. We have so much work to do in terms of connecting with communities across DC and beyond, and understanding the group-specific needs. So we hope that today's the beginning rather than any attempt at a definitive word.
Well, that's a great transition and a great preview for the rest of our presentations. We thank you so much for a very comprehensive overview and update for this rapidly evolving pandemic, and hope that this is the beginning of ongoing conversations about that. And with that, we will transition to Dr. Kendig. Dr. Newton Kendig will provide an update on COVID-19 among incarcerated criminal justice involved populations.
Thank you, Carla. Can you hear me?
Yes, we can. Thank you.
Well, I'm pleased to be here to present on correctional health populations. And I spent most of my career in correctional health care, both with the Federal Bureau of Prisons for 20 years and the state of Maryland for 5 years. I was always concerned that we would have a COVID-19 type of pathogen that was a respiratory disease that was hard to contain. And it's amazing the challenges that are faced day in and day out by our correctional workers trying to manage this very difficult pandemic. One of the focuses for today, of course, is racial and ethnic disparities. And I'm sure this audience is well aware that these disparities are dramatic in the criminal justice system. If you look at the representation of Black men and Latino men compared to white men, it is dramatic, and that is also true for women. And as we just heard from Dr. Axelrod, many of these minority patient populations come from communities of poverty. They have not accessed health care, and they've experienced violence in their communities and as children, and often have chronic medical conditions that predispose them to morbidity and mortality related to COVID-19. Who are these patients? Where are they located throughout the country? This data from the Prison Policy Initiative shows that the over 2 million patients who receive their care in a carceral setting in the United States are in a wide range of facilities. The majority in the pie are state prisons. We also have a large number, thousands of local jails throughout the country who house predominantly non-convicted persons. We also have a smaller group in the federal system, but we also have patients who would be our pediatric patients, adolescents in juvenile detention facilities, as well as immigrant patient populations in ICE detention. We have Native Americans in tribal local jails. So a wide range of facilities providing patient care in corrections in 2020. You saw in the previous slide that the majority of patients are actually in prisons, but if you look at this slide from Emory, the vast majority of patients who are leaving corrections are leaving from jails, 95% of the 10 million releasees every year. And they're going to local jails. Every county in the United States has a local jail. So this has huge implications for public health, and particularly COVID-19, that these releasees are returning to communities throughout the United States, whether urban, whether rural, whether red, blue states, every county has a local jail with populations returning to the community. I always like to put infectious diseases and corrections in context, and we're going to talk a lot about contagion and the risk of incubation of infectious diseases, particularly with COVID-19. But the partnership between public health and public safety is really critical in this country. We can do a great job detecting infectious diseases within the correctional arena. We think of syphilis, for example, in large urban centers, in detecting a disease that often eludes traditional healthcare networks. If you think that 1/3 of hepatitis C patients go through correctional system every year, we will not cure hepatitis C in this nation if we don't provide that treatment, that curative treatment to incarcerated patient populations. But correctional systems also can be a source of contagion. And if you think about the close quarters that has resulted from mass incarceration over the past several decades with overcrowding in many jails and prisons, you can see that close contact is inescapable. You may or may not know that the first community-associated MRSA infections, MRSA infections, occurred in state prison systems in the United States. And certainly we get concerned about ectoparasites like scabies from close contact. But what really has concerned us the most, and certainly in my tenure as medical director, were respiratory pathogens. And indeed, this slide from 1918 in Fort Riley, Kansas, showed that the influenza that started in 1918 in our last pandemic first showed up in a military barracks congregate setting, and soon thereafter in San Quentin Prison in California. And indeed, seasonal influenza has had significant impact on correctional health care. Fortunately, this is largely a vaccine-mediated disease in part, which we don't have for COVID-19, but we have had cases that have really brought correctional systems to their knees when seasonal influenza has been particularly severe in certain parts of the country. And just to give a brief context, other respiratory pathogens, in 1991, there was a large outbreak of MDR-TB in the New York correctional system. It spread from a state hospital where inmates with TB transmitted it one to another, and then those inmates went to state facilities throughout the state of New York, eventually affecting 23 of 68 state prisons. Many of these multi-drug resistant, difficult to treat, with multiple patient deaths. Of course, with TB, it's a pathogen that's cellular immunity can contain in large part. We can treat latent TB. We can use effective contact tracing to limit it. And much of this was fueled by the HIV epidemic. So TB outbreaks still occur, largely in foreign-born populations in correctional settings, but not the large outbreaks we saw back in the 90s. But we have seen other respiratory pathogens in the recent past. CDC reported about significant mumps outbreak. Mumps is a difficult disease, asymptomatic transmission, It's hard to control. Yes, its vaccine can be protective, but vaccine immunity wanes over time. And in particularly when you have immigrant populations who may not be vaccinated, this has created outbreak settings, particularly in ICE facilities, dramatic nationwide outbreak reported in 2019. You can see the numbers, almost 1,000 cases in 57 ICE facilities in 19 states. So what about COVID-19? This is unprecedented for many of the reasons that you're all aware of, the congregate setting with overcrowding, the highly contagious nature of this virus, its significant morbidity and mortality. We don't have available, reliable testing. You just heard about that. And we don't have antivirals or a vaccine. But what's unique about corrections is we have the public safety overlay, where public safety is paramount. It's the mission of corrections. We have to search individuals as part of the correctional work, so there's close contact. And for safety reasons, you may need to lock down jails and prisons. You also have the issue of bringing infection into the prison from staff, or staff bringing the infection from the prison to the community. We'll have the issue of incarcerated patients doing the same for releases or new admissions. But the biggest concern that has evolved and is evolving as we speak for transmission within the correctional environment is our increasing appreciation of the dramatic asymptomatic transmission that occurs with COVID-19. We need more peer-reviewed data. I've included some of the news headlines that have just been nationwide and been shocking to me in many ways, that many of the patients that are in our correctional systems, at least in these early reports, that have COVID-19 are asymptomatic. One of the largest outbreaks in the state of Ohio occurred in the Marion Correctional Institution. So they did broad-based testing and showed 73% of the individuals there that were incarcerated had COVID-19, nearly all asymptomatic. Similarly, in Michigan, in Lakeland Correctional Facility, one of the larger outbreaks in the state, so they did widespread testing. Over half of the inmates were infected with COVID-19. In the peer-reviewed literature, just this week in the New England Journal of Medicine, Aaron and colleagues reported on an outbreak in a Washington state nursing home and reported that 50% of the residents with COVID-19 were asymptomatic. Of course, this has huge implications for infection prevention and control if patients are transmitting the virus and not being aware of their symptoms, so they cannot be isolated and contained. What about the numbers of cases in the United States that involve incarcerated patients? We really do not know, primarily because widespread testing has just been started, and because there's no actual reporting requirements or collection of this data on a national basis. We do know the Federal Bureau of Prisons has nearly half of their facilities affected nationwide, with 28 deaths. DC jail, you see the numbers, 127 patients with the COVID-19, 1 death from one resident and 1 death from correctional officers. And if you look at national data out of UCLA, you can see 12,000 cases, 172 deaths for incarcerated patients, and correctional staff 6,000 cases and 23 deaths. Those deaths of correctional staff have been frontline officers. It's been a warden in Louisiana, a medical director, and a nurse. So really a wide range of correctional staff across multiple departments within a correctional institution. The Centers for Disease Control has issued really stellar guidance specific for corrections. I was really glad to see that in March 23rd. The key guidance is listed here. I won't go through this in detail. I was able to work with this guidance with a colleague of mine, Sarah Burr, formerly the Chief of Infection Control from the Federal Bureau of Prisons, to develop a response plan that was very adaptable, taking the CDC guidance and putting it into a work plan. And that will be available on our website here at GW, or you can email me and I can send it to you. It's really critical that the CDC guidance is adapted at the local level. So personal protective equipment may or may not be available at a local site. You may be in a high rise or a dorm, and your ability to isolate may be very variable. So it is very important at the local level that the CDC guidance is adapted to that setting so it is meaningfully implemented. So if you are the infection control nurse at this site, you have your hands full. How are you going to socially distance this population? There are things that you can do in the dorm setting, head to toe sleeping, really all hands on deck, literally, for hand hygiene and sanitation. And of course, you can reduce the population to increase the distance between patients. But they're very practical issues, such as CPAP. What do you do with your patients in this dorm who are on CPAP? So this is the kind of practical guidance we are providing in our plan to jails and prisons throughout the United States. But courts have, or the jails and prisons have struggled implementing the CDC guidelines because of pictures like I just showed you, trying to really have the kind of sanitation and social distancing that is recommended by the CDC. And the federal courts are starting to weigh in. You may be aware here locally that the federal judge ordered DC jail to improve sanitation and increase social distancing. We also saw in Cook County very specific federal judge orders to ban double cells, a decreased capacity of dorms, providing masks to all detainees, and sanitizing frequently touched surfaces and objects. There are myriad litigation across the country that's active. The University of Michigan Clearinghouse Law School site has a list of over 109 active cases if you're interested. So clearly, a key strategy for corrections is to decrease overcrowding and decrease the incarcerated patient population, and doing that while balancing public safety concerns. Two headlines from Rikers, very different. One, minor parole violation, go to jail, patient died of COVID. Second headline, Rikers Island, New York City, man released, arrested on rape charge. So clearly we need to balance releasing patients with public safety, but there has been, I would say, a very positive movement forward by local and state correctional systems to reduce their correctional populations while maintaining public safety as much as possible. These releases have been through a variety of means. There are many systems that have medical parole, have good time credit to release individuals who are detained or sentenced. We've had governors issue executive orders, federal judges issue orders, as you saw, and advocacy initiatives have been very effective, particularly in the pretrial setting, where you have persons who aren't even convicted of offenses in local jails. If you're interested in many of the initiatives, over 86 listed in the Prison Policy Initiative website, I've listed that link. And these are some of the things that have been recommended for reducing incarcerated patient populations. And many of these have been implemented in the 86 jurisdictions that I just mentioned. I want to focus, though, not so much on the public safety risk, which I think can be managed well if it's thoughtfully done as far as determining who is being released. But I am very concerned about the medical care being provided to patients that are being released from jails and prisons throughout the United States. I'm concerned because release is a high-risk time for our patients, high-risk time for overdose, for linkage to medical care, particularly for the seriously mentally ill and those with complicated medical conditions. And so our incarcerated patients are being released into communities where the availability for chronic care is very limited in many cases. So that is a concern. I'm also concerned about our geriatric patients in infirmaries throughout prisons in the United States who may be medically paroled, which is certainly, I'm all for that, but it needs to be done safely because the medical parole may be transferred to a nursing home that may have a COVID outbreak, or they may be released to a homeless shelter that also has COVID challenges. So those handoffs have to be safely executed and thoughtful. It's not just a matter of releasing a patient from a jail or prison, it's being concerned about their disposition and whether or not the housing that they will have in the community will be safe and they will have access to necessary medical care. And thirdly, there's also obviously the infection control issue of releasing somebody from a jail or prison that has a current COVID outbreak and then transmitting it to the community-based population. And you particularly concerned of returning patients to high-rise congregate settings in the community that could lead to outbreaks there. So very complicated challenge for corrections, but one that we need to be mindful of as we try to reduce incarcerated populations to improve social distancing and manage the outbreak. So what are the strategies that we can implement across the country to manage COVID-19 in jails and prisons? I've listed some of the key recommendations that I would make. First and foremost, we don't want corrections and local public health to be antagonistic. We want them to be synergistic. Every county jail has a local health department. That engagement is more vital than ever before if we're going to have meaningful recommendations, assistance from local public health as far as what we can do at the local level to contain COVID-19. We need to improve sanitation and hygiene. That may be more liberal with alcohol-based sanitizers, which are largely either prohibited or limited for security reasons. And you're starting to see even judges say, no, these sanitizers must be made more available to incarcerated populations. We need to prioritize PPE for congregate settings. That includes our correctional workers and our incarcerated patients. We shouldn't be at the bottom of the list for difficult to find PPE. I would argue congregate settings should be at the top of the list for where we need them most. We need to enforce social distancing as much as possible, and that may mean leveraging virtual smart technologies as much as possible for virtual education, for example, in ways in which we can provide programming to our incarcerated populations without group activities or limiting group activities. You're starting to see copays for medical care either reduced, suspended, or eliminated. And I think you'll continue to see that push for really encouraging incarcerated patients to come forward, even with minimal symptoms, so they can be diagnosed and managed with COVID-19 and isolated if necessary. We need to reduce costs of phone or video calls. It's very isolating just on any given day. It's obviously isolating to be incarcerated, and now nearly all jails and prisons have reduced visitations with families, with children not having access to parents. So I was glad to see that Federal Bureau of Prison actually discontinued costs for patients having access either by phone or video to their families. And we should, as we talked about, look at ways of meaningfully reducing the patient populations while maintaining public safety. But I'd like to close with, I think, two of the more provocative questions that I think corrections will be facing in the very near future. The first has to do with antibody testing. As we have more availability for antibody testing and hopefully better sensitivity for these tests, and if we find that they actually confer long-term immunity, which we just heard from Dr. Axelrod is not certain, but is certainly a possibility, it just raises very interesting questions for corrections. Should we screen persons prior to release to the community to make sure they're not contagious? Should we screen correctional workers to both protect the workers and to protect incarcerated patients? And will it allow us to create COVID-19 safe housing units or even prisons? And also, will these units or prisons even evolve naturally over time with herd immunity if we're seeing the kind of widespread transmission that was evident in Ohio and Michigan? If this is going to be true across the country, it has real implications, particularly in a longstanding high security penitentiary where the population is stable, as to whether or not these institutions will basically have become infected with COVID-19 and immune. That's all much of conjecture, but I do think it's worth looking at the data as it starts to come out from other systems as we start to do more widespread testing for COVID-19 antibodies. And then the second issue, which is also a bit provocative, but as we develop COVID-19 vaccines, should we be considering incarcerated populations? Are they a high-risk population for transmission? Absolutely. We know that that is true. Are there ethical considerations for doing research, interventional therapeutic type research within the correctional setting? Absolutely. There have been certainly major abuses of research involving prisoners in the United States historically. But just as an anecdote, when I was in the state of Maryland in the middle of the AIDS epidemic, I really advocated for access Maryland state inmates to antiretroviral clinical trials. And we were able to get that approved with a collaboration with Johns Hopkins and approval from the federal government to enroll state inmates into antiretroviral clinical trials, which many of these interventions, as you know, proved to be life-saving for patients otherwise dying of AIDS. So I do think we need to have a real discussion on whether the correctional populations should be considered for vaccine trials, certainly trials that are not just provided to the patients that are incarcerated. These would be vaccines that are also being provided to non-incarcerated populations. But I think this discussion is really worth having and certainly making sure that the ethical considerations that are mandated by the Office of Protection for Research Risk out of the federal government are adhered to. So in closing, you know, my mantra is that congregate settings matter. I've spent my career really advocating that correctional health care is public health care. And I think COVID-19 has really brought this to the forefront. Our patients that are in nursing homes, the elderly, they matter from a public health standpoint. Our men and women on aircraft carriers in the military, they matter from a public health standpoint. Our homeless populations in crowded conditions in shelters, they matter from a public health standpoint. And certainly our incarcerated patients who are often marginalized, who often have significant healthcare needs prior to even coming into the system and now are exposed to a potentially lethal contagious disease. Our incarcerated patient populations matter as well, now more than ever, to the public health of our nation. And with that, Carla, I don't know if there are any questions, but that concludes my talk.
Well, thank you so much for that overview. I think it also provided a great insight, both in terms of the incarcerated populations and the health challenges that we face with them, but also congregate settings more broadly. So thank you for including that. We do have a couple of questions. One is that you mentioned the strategies include PPE, including PPE for incarcerated populations, what does that look like for PPE for incarcerated populations? Is that masks, or what are we looking for there?
Well, a lot of that is going to depend on the availability of masks. You may have seen that many state correctional systems are using their factories for the incarcerated population to help self-make masks for their system. And certainly my experience with that is that most individuals that are incarcerated will step to the plate and say, I want to help. That's been my experience with incarcerated patient populations, but it really doesn't depend on what's available. Um, a couple weeks ago, when I talked to my colleagues in corrections, none of the persons that were incarcerated had access to PPE. And then you started to see PPE issued to correctional staff. And then I would say a week ago, I started to see widespread issuance of surgical type masks, or some of it adapted, not the traditional surgical mask, being handed out to populations that are incarcerated. And you're starting to see even now judicial recommendations and orders that these masks be provided. So it's a mix. It's a mix of what's available, and I would say it's now just more broadly being implemented, and an expectation that in a housing unit, your incarcerated population will have access to surgical type masks.
Very helpful, thank you. And some of your discussion focused on the period after release, that is particularly the needs of those with complex and or chronic conditions. And we have a question about whether systems actually exist, whether the health system can accommodate or have been put in place. In addition, whether the individuals are being tested before release for COVID-19, and if so, are they held until we know the results of their test or screening test?
Well, the state and federal systems are doing different things. In some systems, they are holding, I didn't mention this, so I'm glad this was brought up. In some systems, they are creating sort of a quarantine of 14 days prior to release. Testing is not really viable at this point because of the issues we talked about earlier today on the reliability and the sensitivity of antibody testing. I do think, as I mentioned, if the antibody testing is improved, that would be a way to screen individuals prior to release. So I think that may evolve over time. But for the present time, symptom screening and holding patients 14 days prior to release to the community.
Great. And some of the issues of disparities have been raised as well. That is, are we seeing, we know that there's a large racial and other disparities among those who are incarcerated. Within the incarcerated populations, are we seeing any disparities within incarcerated populations, or do we know?
We don't know. And I think, as was Dr. Axelrod mentioned, uh, we need to do a better job epidemiologically in this country, tracking COVID-19 morbidity and mortality as it relates to race and ethnicity. It's certainly not being done in the justice involved populations. And it's vital that we have this information for the epidemiology to guide our patient care and our allocation of resources for this population.
Right. And for people who are working in the healthcare setting that might interface with jails and other congregate settings, should they be tested before being sent to perhaps jail or other facilities, and then await the result? Or how is that handled, or is that being addressed now?
I think it's going to depend on how engaged public health and the community is with these releasing patient populations. Certainly anybody who's being released who's sick needs to receive care, but the vast majority of persons leaving jail and prison are hopefully going to have gone through that quarantine period, have been asymptomatic, and my main concern is that they have access to care in an environment where access to care for chronic care is in a more limited right now, just because the focus has been on COVID-19. There are ways that we can engage our population remotely, just as we're doing in GW, and so telehealth can be vital here. If the individuals can get access to providers virtually, that would obviously be an optimal strategy.
Right. Right. Well, you raised some very interesting points and things that we don't always necessarily have access to learning much about. So we so appreciate your presentation and your perspective and years of experience that you've shared with us. Our great appreciation for that, and we look forward to ongoing conversations as well. Thank you again, and we will begin transitioning to our next presentation. For this, Dr. Kara Lichtenstein has offered and is willing to provide a brief discussion about health disparities in the context of COVID-19. And so with that, I will transition and pass it over to you.
Hi, everybody. Can you hear me?
We can. Thank you.
Okay. Well, good morning, everyone. I am honored to be invited to speak today. Thank you so much, Dr. Bartholomew, for including me in this session. As you heard, my name is Kara Lichtenstein, and I'm here to talk to you today about health disparities in the time of COVID-19. We only have a short time together, so I want to dive right in, but I do want to give one caveat first. So my day job, where I am right now, is as a primary care pediatrician at the Children's Health Center Anacostia. But teaching and learning about health disparities is one of my greatest passions. By no means do I have all the answers, though. So I hope to cover most of your questions during the presentation, and there will be time for questions at the end. But if I don't answer your question, or you have a question that we didn't have time to get to today, please feel free to reach out to me. My contact information will be on the last slide. So if you're anything like me, the news headlines in the last 6 weeks may have made you feel a bit overwhelmed. Yet in recent days, in addition to feeling overwhelmed, I've also started to see more and more headlines that have made me mad, sad, and angry. Have you guys seen any of these? Hopefully by the end of today, we will all have a better understanding of why we may be seeing these kinds of headlines. Specifically, what I hope to cover is these following learning objectives. So I want you, by the end of this session, to feel like you're able to describe the groups that are most affected by COVID-19, explain how social determinants of health contribute to poor outcomes for certain groups in the present epidemic, and place what is happening today in the context of the history of the health disparities in this country. So we're going to spend the next 20 minutes or so answering these interrogative questions. Let's start with what? But before we even get there, I want to make sure that we are all on the same page when I use certain words. I'm a visual person, so a picture like this helps me to understand concepts that sometimes seem abstract. You may also have seen this concept explained with a picture of people standing outside the fence at a baseball game. I much prefer cycling to baseball myself, so you're getting this picture today. In a state of equality, which is represented in the top panel, everybody has the same resources to access health-promoting activities. But if you look closely, that resource seems to only fit one person well and completely leaves out others. In the state of equity, on the other hand, everyone has exactly what he or she needs to participate in the health promotion activity. So how does that translate into a definition of health disparities? According to the CDC, a health disparity is a particular type of health difference that is closely linked with social or economic disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, mental health, cognitive, sensory, or physical ability, sexual orientation, geographic isolation, or other characteristics historically linked to discrimination or exclusion. So let's explore some of the historical discriminatory factors that have led to disparities in this country. Although we just heard that the disparities do not just exist along lines of race, ethnicity, this is what we're hearing a lot about these days. So that's where I'm going to explore further. I think the biggest piece of the historical puzzle that you'll hear people talking about is structural racism. Structural racism is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial inequities. One of the most prominent examples is the practice of redlining. The term redlining comes from the 1930s when the Federal Housing Administration began making maps with red lines to delineate neighborhoods where mortgages were to be denied because residents were deemed more likely to default on their loans. These neighborhoods generally consisted of Black and brown people. Although this practice is now outlawed, it had long-term consequences in terms of ability of minorities to build financial capital. It also changed the demographic pattern in communities across the U.S., leading to residential segregation. And it continues today in the form of housing discrimination and disinvestment in communities of color. Another example of structural racism is the Social Security Act of 1935, which created an important system of employment-based old age insurance and unemployment compensation. But the act deliberately excluded agricultural workers and domestic servants, which were occupations largely held by Black men and women at the time. This racially motivated exclusion gave the primarily white recipients of Social Security the opportunity to gain wealth and pass it on to their children, while those who were excluded were unable to do so and instead often became dependent on their children after retirement, further reducing the intergenerational accumulation of assets. The net result has been an entrenchment of racial economic inequities that persist to this day. Another example is the war on drugs and tough on crime policies enacted in the 1970s and 80s, which disproportionately targeted Black people for incarceration, leaving a legacy in this country where the annual rate of incarceration of Black men is 3.8 to 10.5 times greater than that of white men across all age groups. And I believe you just heard about that population. Implicit bias refers to the stereotypes or attitudes that affect our understanding, actions, and decisions in an unconscious way. Although implicit bias is not limited to race, studies have found that implicit bias can often influence patient-provider interactions, treatment decisions, treatment adherence, and therefore affect patient health outcomes. And blatant racism also needs to be mentioned. It too has an effect on health disparities. In addition to the stress axis that I believe Dr. Axelrod spoke about earlier, there's strong evidence for continued racial discrimination in things like hiring decisions. And as we will see a little later, job role can have a huge influence on exposure to a disease like coronavirus. So let me move next to the why. So why do factors such as housing conditions or job hiring matter? I'm sure that you have all seen pictures like this in the past, so I won't dwell here too long, but healthcare is believed to contribute only about 20% of health, whereas other things such as the physical environment and socioeconomic factors make up 50% of health. Quality education, employment, livable wages, healthy food, stable and affordable housing, and safe and sustainable communities are factors that go a long way towards shaping health. So who is being affected by these disparities in the present pandemic? In this data, which is from 2 days ago, you can see that the COVID-19 mortality rate for Black Americans is 2.5 times higher than the rate for Latinos, 2.6 times the rate for Asians, and 2.7 times higher than the rate for whites. While Black Americans have suffered disproportionate losses in a majority of places, in some areas, their death toll is exceptionally high. In 7 states and the District of Columbia, Mortality rates for Black residents far exceed the national rate of 28.4 deaths per 100,000 Blacks. This is seen most dramatically in New York State with 141.9 deaths per 100,000 Black residents. And unfortunately, Washington, D.C. has also seen big disparities with a death rate of 47.2 per 100,000 Black residents. And the difference between Black rates' share of deaths and share of population in D.C. is greater than 30 percentage points. Other minority communities included in this graph are faring slightly better. 6,400 Latino Americans are known to have lost their lives to COVID-19 through April 27th. For each 100,000 Americans of Latino descent, about 11 Latinos have died from COVID-19, which is a mortality rate nearly the same as Asians and whites, but still well below Blacks. Latino Americans are dying at rates above their population share in 2 states, New York and Missouri. In New York, Latinos comprise 19% of the population, but have suffered 26% of the deaths. One population that you do not see included on this chart is Native Americans, which they say was due to inconsistent data to be able to be included in this graph. But there are some groups that are keeping track, including the sovereign Native American nations. For example, as of last week, the Navajo Nation health officials were reporting 1,590 known coronavirus infections across the Navajo Nation, resulting in 58 deaths. And as of April 24th, the Indian Health System reported 2,045 cases confirmed and 76 deaths. So we know that this is a problem, and we know many reasons why, but at this point, we cannot truly say how big of a problem it is because we need more data. As of Monday, April 27th, only 40 states were reporting confirmed cases by race, only 36 were reporting deaths by race, and only 2 were reporting testing by race. And this does not even account for the myriad of other factors that influence health besides race and ethnicity. So we know that minorities are being deeply affected by disparities in this pandemic, but what about other populations? Who else do we need to consider? You have already heard this morning about imprisoned and justice-involved population, and you will be hearing more about the immigrant population immediately after my talk. I think the elderly go without saying, but there are other groups too. What about people living in crowded housing conditions or those who are not even housed? There are other institutionalized settings, such as group homes and nursing homes, that are putting certain groups at much higher risk. And what if you don't speak English? How are you able to access all the messaging around this pandemic? And then there is the population living in poverty, which I will talk about in a few slides. So let's tie this all together and talk about how these disparities are playing out in the COVID-19 epidemic. As more data about the impact of the COVID-19 pandemic becomes available, it is increasingly clear that the disease is hitting the most vulnerable and disadvantaged populations in the U.S. the hardest, which we just learned are often communities of color due to things like structural racism. Due to this history, African Americans and other people of color in the U.S. have higher rates of poverty, housing and food insecurity, unemployment and underemployment, and chronic medical conditions and disabilities such as asthma, obesity, diabetes, and kidney disease. So I think that the relationship between COVID-19 morbidity and mortality and chronic medical conditions is obvious. But let's spend a few minutes talking about poverty. How could poverty lead to increased risk? If you are poor, you may need to rely on public transportation to get around. Or you may need to shop more frequently because you have less available money to spend. Or you may have no space in your home in which to stockpile what you are buying. You may also be living in a more crowded setting. All of these together increase your risk. And remember, in this country, there are higher poverty rates for racial and ethnic minorities. You also hear a lot about stay-at-home orders. But what if you can't stay at home? There is also an overrepresentation of minorities in essential jobs in transportation, government, healthcare, and food supply service, which means higher risk of exposure at work. Also, many work in low-wage or temporary jobs that may not allow telework or paid sick leave. As you can see from this graphic, all the factors that make it less likely that you can actually work from home have an overrepresentation by communities of color. But what about things like testing and treatment? In the early days, only those who had traveled to certain countries like China or Italy could get tested, but this was not relevant for many of the poor. The guidelines for testing have since expanded significantly, but still, many of our most vulnerable populations do not have access to testing. Why is that? Could cost be a factor? Congress mandated that Medicare, Medicaid, and other government plans and most private plans cover COVID-19 and all testing-related services entirely. But what if you have no health insurance? 8.5% of people in the U.S., nearly 28 million individuals did not have health insurance at any point during 2018. And the DC insurance rate in 2018, the most recent year for which I could find information, was 3.2%. Given that 56% of Americans receive health insurance coverage through their employers, it is likely that millions of people have recently lost their health insurance along with their jobs. And then comes the question of how do you get the test done? DC has done a good job of having test sites that are not only drive-through but also walk-up. But what if you cannot leave your home? Additionally, most of these testing sites require that you have a referral from your doctor, which means those without a primary care doctor may have a hard time even getting a test. And since many primary care doctors are now doing mostly telemedicine visits, if you have a primary care doctor but no internet access, then you may also have problems getting that referral. And all of this does not even touch on the cost of treatment, which has been estimated to average about $73,000. So where does that leave us? So for anyone with any experience in the field of disparities, what we are seeing with COVID-19 comes as no surprise and is actually expected. As far back as the 19th century, scientist and pathologist Rudolf Virchow recognized the role of poverty and disadvantage in disease. Sir Michael Marmot's 1978 Whitehall study, where he looked at public servants in England, showed that being from a privileged class significantly lowered the risk of cardiovascular disease. Since that time, there have been innumerable studies showing similar relationships in a variety of diseases, yet not much has changed. This graph was taken from the annual National Healthcare Quality and Disparities Report from the Agency for Healthcare Research Quality, which is mandated by Congress to provide a comprehensive overview of the quality of healthcare received by the general U.S. population and disparities in care experienced by different racial and socioeconomic groups. The report assesses the performance of our healthcare system and identifies areas of strengths and weaknesses as well as disparities for access to healthcare and quality of healthcare. The graph I am showing here is from the 2017 report, which reflects data from 2014 to 2015, and it showed that for 40% of quality measures, Blacks were worse off compared to whites, 20% worse for Asians, 30% for American Indians, Alaskan Natives, 33% for Native Hawaiians, Pacific Islanders, and 33% worse for Hispanics. And the unfortunate news is that all these metrics worsened in the most recent report available from 2018, with the number of disparities improving for only 4 measures for Blacks. Those are in this chart, those are what's pictured in green. 2 measures for Asians, 2 measures for American Indian and Alaskan Natives, 1 measure for Native Hawaiian and Pacific Islanders, and 5 measures for Hispanics. But I don't want to leave you feeling hopeless. I think that the stark disparities seen during this pandemic have been a huge wake-up call for our society. Many more people are now talking about disparities and the need to collect population data by race and ethnicity, especially within this present pandemic. I'm hopeful that this means that we will start seeing research and funding being directed towards studying how to address these disparities and improve the health of our entire population. Thank you for your time. I am now open to taking your questions.
Well, that's great. Thank you for that just wonderful overview of disparities, particularly as it relates to COVID-19. There was an earlier comment and question regarding discussion of race in the media, specifically looking at race as a risk factor rather than as just a variable in epidemiology. Is that something that you have identified in some of your work on this, or is that something that you can share any thoughts about?
So we were privileged enough to have Philip Aliberti from the AAMC come give a grand round at Children's National recently. And one of his big points, and I'm going to steal it from him, is that it's not race that's causing the problem, it's racism. So race is a social construct, so there's nothing specific about someone who's identified as a certain race that makes them more susceptible to this disease. It's the long-standing history of racism in our country that has set certain groups of people up to be in a disadvantaged position.
Right, and that, thank you. And that really piggybacks on another comment about how discriminatory policy has been longstanding, which you did a wonderful job of raising, but that is often used as a proxy for race, that, you know, rather than seeing it as an impact, it's used as a proxy, and exacerbated by many of the factors that we see, such as resource allocation, et cetera. There is a question definitely within your wheelhouse of pediatrics, and that is whether, you know, we are seeing disparities among pediatric populations in COVID-19 incidents and or outcomes.
So this is one of, yes, it is within my wheelhouse, but I don't have that data at my fingertips. What I will say is that at Children's National, we have obviously treating kids with COVID-19, and the population that we see is taken from DC, where there is a large groups of minority populations, and our positive rate has been higher than some of the other children's hospitals in the country. And the question became, was this significant? I don't think anyone has answered that question. I'm not sure how far they've looked into it. None of the data reports that I saw broke out by age, and so that's another issue. A lot of the reports that I'm seeing are not breaking out by age, so it's hard to tell what exactly is happening in the pediatric population. Just the anecdotal evidence that Children's National rates of positive coronavirus testing was higher than some of the other pediatric hospitals in the country that didn't have such a large minority population. So right now, I can only speak to the anecdotal nature of it. I have not seen any solid scientific data that would answer that question in a more scientific manner.
Thank you. And one of the issues that you raised as a factor in the structural and upstream issues was just, as you said, blatant racism. Are there efforts being made, you know, globally or certainly within the GW and children's family to address some of the potential for discrimination in the treatment and medical context? Are there any things that are being looked at in the COVID-19 or in the broader context?
So that's a great question. I can give you one example. So one of the things that Children's National did early on was they created this community-based pop-up site for testing, and they made the site accessible to people both walking and in cars. So, you know, a lot of the population that I see in the health center that I serve in Anacostia don't have cars. So to have a testing site that requires people to stay in their car is pretty discriminatory towards people who don't have that access. And so a policy like that, where they're thinking about the community and thinking about what barriers certain communities might face to things like testing, has manifested in things like walk-through testing in the District of Columbia. I know the mayor also has addressed some of the disparities and is working and partnering with community organizations. So I think there's been a lot of partnering both from the government level and the institutional level, partnering with community-based organizations to get education out there to help people to know more about this disease so that they can take care of themselves, and trying to reach out to the marginalized communities who may not otherwise have access, but may have access to the community-based organization. So I know the Rodham Institute has been doing a lot of work. I know Martha's Table has been doing a lot of work. At Children's National, our Child Health Advocacy Institute has been doing a lot of work. So it's more along the lines of making sure that we're reaching out to the communities that may otherwise not get the information, services, resources that they need in this pandemic, and making sure everybody's included under that umbrella.
Thank you for that. And a related question of whether our clinical guidelines, decision-making tools, et cetera, either, at the national level and or at the organizational and hospital institution level, those have the potential for perpetuating discrimination, racism, and disparities. Is that something that's being looked at, or is that being discussed currently that you know of?
So I'm not involved in the creation of any testing guidelines, but I will say that early on, when the national guidelines, as I mentioned in my talk, were testing guidelines were solely based on travel or known contact, when so few people were getting tested, there was a lot of discussion about how do we broaden that to include the community that we serve. So I agree, early on the testing guidelines were very, perpetuated some of the disparities, and people who were getting COVID-19 through community contact were being missed because they weren't being tested because they didn't meet those strict criteria. The criteria for testing now are much broader, and at least at our site, they include things like if you have to go, if you need to go to work, that we would test you so that we know if you're at risk and you're putting others at risk. So I mentioned in my talk that many of the essential workers are from lower socioeconomic status because they can't work from home. And so there's definitely been a change over time in the policies, and I think taking into account the fact that they were discriminatory policies. Are they perfect? No, I don't think they're perfect, because we still don't have universal testing of everyone. And honestly, I can only speak to sort of the pediatric testing criteria because that's what I have intimate knowledge of. But I think as more tests become available, we're trying to broaden the scope. And I think some of that discussion around how discriminatory the early guidelines were is part of that discussion. And there are definitely people in Congress that are leading the charge towards demanding data by race. So that's something that, on a national level is being really advocated for by certain members of Congress.
That's great. And our final question relates to the mention of social determinants of health. In our last symposium, we were fortunate to have a couple of folks from the Children's Law Center who discussed, as you might imagine, the issues related to food security, education, particularly special ed, and then other social determinants and the policies that are influencing and impacting those various social determinants. Is this something that you are seeing people in the healthcare setting work with other partners, such as medical legal partnerships, et cetera, to address some of those social determinants to reduce disparities? Are you seeing that here in DC, and then are you seeing it, perhaps more broadly?
So I will say that I am seeing it here in DC. We ourselves have a partnership with the Children's Law Center, and they are still, even though they're working virtually, they're still working with us and our families to try and make sure that they have, they can help them through some of the issues that would be considered social determinants of health. We do Also, we'll give a shout out to some of the medical students who have put together an amazing resource that has resources that address some of the social determinants of health for families, not just for pediatrics, for all ages in the District of Columbia. It's a great resource to be able to refer families to. And then I will also shout out to the coronavirus.dc.gov website that has been put together by the DC government that has resources available. So all of us are quite aware of how the social determinants of health are playing into this pandemic and are more acutely aware of making sure that our families have the resources that they need. And I believe the DC government is aware as well and has made available many new resources. And, you know, just for example, in I think almost every jurisdiction in this country, the schools are still handing out school lunches because so many kids are dependent on that in lower income settings, are dependent on the school meals to get their nutrition. And I think in most states around the country, if not all, the schools are still handing out meals to students because we realize that this is a big problem in the pandemic. So I think people are very aware of how this pandemic has worsened conditions in factors that are social determinants of health, and working hard to address that both institutionally, locally, and nationally.
That's great. Thank you so much for a wonderful presentation and for a very robust Q&A session as well. We greatly appreciate that. And with that, we'll begin to transition to our next presentation. Dr. Lanre Falusi will be discussing COVID-19 among immigrant populations.
Good morning. Can you all hear me?
We can, thank you.
Great. Thank you all so much for your attention and your time today. Thank you, Dr. Bartholomew, and the entire Clinical Public Health Learning team for the invitation to speak with you all about one of my favorite topics, which is around immigrant populations, and is a perfect segue after Dr. Lichtenstein's talk on disparities. I come at this as a clinician. I'm a general pediatrician at Children's National, seeing patients at our Columbia Heights Health Center that has a largely immigrant population. I'm also a faculty member in our Child Health Advocacy Institute and an assistant program director in our residency program. So it's a clinical research, advocacy, and educational passion of mine. So we'll jump right in. So also starting here with some headlines that you may have seen as it relates to immigrant populations and COVID-19. There, you may have seen this White House proclamation suspending entry of the majority of immigrants into the United States, or immigrants in detention centers testing positive for COVID-19, or ICE, which is the Immigration and Customs Enforcement, not reporting the detention center staff members who have tested positive. Or even the fear in immigrant communities around accessing care or even testing related to COVID-19, immigrant families and family members who are not qualifying for relief from the federal government, and even doctors who are waiting for green cards as they're on the front lines caring for patients, putting themselves in harm's way, wondering what will happen to them as immigration enforcement really changes in this country. And I just wanted to read this quote from that last article that just really struck me. So this is a physician who is originally from India. So he's an immigrant physician and is treating patients who have COVID-19. And he says, I'm also one of the 300,000 Indians in the United States on an H-1B work visa, waiting in line for a green card that would give me legal permanent residency. My greatest fear is that if I contract and die from COVID-19, my wife, who's on a dependent visa, will be asked to go back to India. My 1-year-old daughter, an American citizen by birth, cannot travel with her, as the Indian government has a travel embargo on all foreign citizens to limit entry of COVID-19 patients. So I think often about my patients who are largely from Central America and other places around the world as we talk about immigrant populations, but also want to point out the fact that we're also talking about physicians and other healthcare providers who are stuck in this limbo right now of caring for patients with COVID-19, but not having this any sort of sense of security or safety in the United States right now. So kind of giving you the lay of the land of immigrant families in the US and in our region, about 1 in 4 children in the US and in DC lives in an immigrant family. So that means either the child or a parent was born outside of the US. Nationwide, this means about 18 million children. 9 out of 10 of these children were actually born in the United States. So in immigrant families, 90% of the time, if they're children, that child was born in the US, even if their parents were not. Latinos, or the Latinx population, is the largest and fastest growing ethnic minority in DC and in the United States. And over 7 million children live in mixed status families, meaning that at least one parent is not a US citizen. So these are the majority of families that I see where the child may have been born in the United States, but their parents were not. And there are lots of implications here around what those parents are eligible for in terms of benefits. And then for the kids as well, what they are probably eligible for, but their parents may not be accessing just due to fear. So specifically around COVID-19, before this pandemic, immigrant families were already facing increasingly restrictive policies and discrimination. And now we're seeing some of those disparities being amplified and new ones emerging, particularly as families are trying to navigate school closures and experiencing educational disparities, lack of health insurance and paid leave, and even making decisions around whether or not to seek medical care or public services while there's ongoing immigration enforcement. So I'm going to break this down into 3 parts as it relates to COVID-19 and immigrant health. First, I'll talk about the health impacts, talk about the socioeconomic impacts, and then I'll mention a little bit about immigration enforcement and policy. So first, with the health impacts, we know that immigrant families are more likely to live in multi-generational households, which increases the risk of COVID-19 transmission when there are multiple family members. Just to give you a picture of this, just yesterday I was in clinic and I saw one family where there were 3 kids. Well, one was a 19-year-old and 2 of her cousins, age 6 and 8. They're all for COVID testing. The 6 and 8-year-old actually live in Virginia with their mom, but with schools being closed and mom having to work, she sent her 6 and 8-year-old to extended family members living in Maryland. At that home now is a 6 and 8-year-old along with their 19-year-old cousin, that 19-year-old's 3-year-old daughter, that 19-year-old sister who's 15, their mom who is in her 60s, and another family member. So 3 generations in this household. The 15-year-old sister tested positive for COVID-19 at another health center a few days ago. The 19-year-old, who is her sister, was there to see me yesterday with her 2 younger cousins. 2 out of the 3 of them ended up testing positive for COVID-19 yesterday. So just kind of a stark reminder that that sheltering in place sometimes means just increasing the risk for everyone within that household. So now in this, sort of densely populated home that they're living in, there are minimum 3, certainly I would say probably more people in that house who now have who are positive for COVID-19. Just with the limited supports that people have to be able to, sort of shelter in place. Rather, we have people congregating in some instances, like with this family, just out of necessity in multi-generational households. Immigrant families are also less likely to have health insurance. Half of undocumented immigrant adults lack health care coverage. Even 1 out of 4 immigrant adults who are here lawfully are uninsured, as are 1 in 3 undocumented children, and nearly 20% of even lawfully present immigrant children in immigrant families have lack of health insurance. And even when families who have limited English proficiency access care, there is lower quality of care, largely due to lack of proper interpretation and translation services, or as Dr. Lichtenstein said earlier, really it's not about race, and here it's also not about necessarily ethnicity or language. It's more about the discrimination. It's about the racism. It's about the fears or lack of respect that some immigrant families encounter when they enter into the healthcare system. And then at this time, we also have these rapidly changing public health directives around sheltering in place, around wearing masks that are not always multilingual or culturally relevant. And having lower English or limited English proficiency is a risk factor. It's also poor outcomes for those reasons that I mentioned. Then to talk briefly about sort of where some of this fear of accessing healthcare services comes from. A large part of it these days comes from this public charge rule, which I know that some of you are familiar with. A public charge is defined by the US government as an individual who's likely to become primarily dependent on the government for subsistence. This has been around for decades. It's one of the things that the government utilizes to make the determination around whether or not someone will be given a green card. For decades, it was pretty narrowly defined. If you got cash assistance from the government, or if you were institutionalized long-term on government funding, then you were maybe less likely to get a green card because the government would worry that you would become primarily dependent on them. This maybe affected about 5% of people applying for visas and green cards over the last several decades. But in February of this year, this definition was vastly expanded to include utilizing programs like Medicaid and SNAP and housing vouchers. And with you all having gone through your PPS courses, I don't have to tell you that, that these are very much directly relevant to the healthcare outcomes of populations. The reality is most people who are in this country that are still applying for a green card or applying for a visa would not actually even qualify for these federal benefits. So the concern really is the chilling effect, which we're already seeing, in that particularly parents who maybe are applying for a green card for themselves and have children who are born in the United States that are on Medicaid or SNAP are choosing to disenroll or to not even enroll, say, a newborn into these programs because of fear of being deported. So we have families who are choosing to take their children off of Medicaid, or I see a lot of newborns who would benefit from WIC or from SNAP, and parents are sometimes choosing not to enroll their infants into those programs. So the effect of this, as it relates to COVID-19, is that entire populations are now afraid to seek testing or care for coronavirus. And you all have heard that with something like COVID-19, where there is no real cure that we have at this time, there's no vaccine that we have at this time. Our biggest defense right now is testing and isolation to reduce the spread. So when messages are put out that cause immigrant families to be afraid to seek medical care, then we're really concerned that we're not doing all that we can and should to limit the spread of this virus. So then moving on to the socioeconomic impacts of COVID-19 on immigrant populations. So we all know that immigration status is a social determinant of health. My bias, again, is always towards thinking about children and families. So children in immigrant families are more likely to experience poverty, food insecurity, housing instability, and lower educational achievement. These all resulting, again, from policies that restrict their access to opportunities, as opposed to any kind of inherent difference, but rather years of limited opportunities for immigrant families. Immigrant adults are also more likely to work in low-wage jobs compared to the overall US population, and to not have paid leave, which discourages people who may be sick to stop working. I mentioned public charge. So even though WIC was not included in the final public charge determination, I know that I and others have documented lower utilization of WIC in our immigrant populations. So at a time like now, when, as we've seen, families have a hard time getting food, whether it's due to income losses or grocery stores being emptied out, now more than ever, we need families to be able to access healthy nutrition. That's becoming more difficult. And then sheltering in place when you don't have childcare is also very difficult, and has resulted in unemployment for some parents. When we think about school closures as well, we know that a lot of school districts have moved towards distance learning, which sounds like a great thing and absolutely should happen to ensure that children continue to learn. But as you see these large programs rolled out, it's always important to ask, is everyone who needs to access this actually getting to it? And the answer really is no, or probably not, at least. We know, for example, that immigrant Latinx families in particular are less connected to broadband internet than other families of similar income levels and those who are lower moderate income. And then also, kids are experiencing disrupted schedules while their parents work. Dr. Lichtenstein mentioned that people in minority communities are more likely to have these essential service sector jobs. And that's definitely true in our immigrant populations as well. And then with immigration enforcement and policy during this pandemic, ICE has continued their activities around deporting and detaining individuals. There has been not quite a directive, but a recommendation from the federal government that only those who are at risk of having or being criminal threats should be detained or deported. But there's been a lot of leeway given to how that is defined. So we also have 27,000 people with deferred action for childhood arrivals working in healthcare in the United States. So DACA, you're probably all familiar with, but very briefly, these are individuals who came to the United States as children with their parents, came without authorization, and now are adults. And you have to be working or in school and have a basically perfectly clean criminal record to obtain DACA. So we have 27,000 people who are sitting in limbo, actually, as there's a Supreme Court decision supposed to be coming this year about whether or not this program will continue, as the administration has tried in a few different ways to dismantle the program. Meanwhile, we have this really multicultural, multilingual workforce within healthcare at a time when we need more interpreters as people are moving towards telemedicine and trying to figure out how you get an interpreter into a Zoom call, for example, or working on the front lines in these fast-paced environments where we have people who are very ill and we can't always wait that 2-3 hours for an interpreter to come. They're also working shoulder to shoulder with all of us and without getting the full benefits of having that safety and security again of staying in the United States and working. In addition, Customs and Border Protection Processing Centers, these are the centers at the border, largely on the US-Mexico border, but also on the US-Canada border. CBP is a law enforcement agency that processes, that detains and then processes people who cross the border without authorization, and even those who are crossing seeking asylum. These detention centers are sometimes adults only, but there are some family detention centers. They're unsanitary at baseline with limited healthcare services, which at this time increases the risk of rapid COVID-19 transmission and risk for serious illnesses. Children who come unaccompanied across the border go through a different process where they actually end up in Office of Refugee Resettlement shelters that are run by Health and Human Services. So these have better services, particularly around healthcare, but still are densely populated. And the problem that we're seeing now is that typically these children would stay a few weeks in a shelter and then would get reunited with a parent or other sponsor in the United States. But there's been a significant slowdown of releasing these kids to sponsors. So rather than going out into the community, they're staying longer in the shelters. And then, finally thinking also about the federal response. I need to update this slide, but to include the $484 billion to small businesses that was released or signed this last week. But the federal government has now released 3 bills to provide support for families and businesses as it relates to COVID-19. I won't go through all of these in detail, but just so you see the sheer amount of money, from $8 billion to $2 trillion for healthcare, for families. This has been just like an unprecedented amount of federal funding in such a short amount of time. I hope you all really recognize the impact and of this. I, in my time, have not seen this happen so quickly and in a actually fairly bipartisan way. But again, as you're seeing these large programs roll out, the question is, who is left out? Who are we not thinking about? And the reality is undocumented immigrants largely are not eligible for this relief. Even millions of children in immigrant families are still ineligible for Medicaid. Medicaid and Medicare is where a lot of this funding for healthcare is coming through with these stimulus bills. COVID-19 testing is covered through these bills at federally qualified health centers, which is great, but treatment costs are not covered. And then finally, these stimulus checks that everyone is waiting for. If anyone in your household uses an ITIN, which a lot of immigrant families do, if they don't have a social security number, then no one in the household will be able to get a stimulus check. So these are families who are paying taxes using not a social security number, but a different number that the IRS actually provides to these families. But if you use that number, meaning you don't have a social security number in the United States, then you actually will not get a stimulus check. And this is true even if you have a social security number and your spouse has an ITIN, neither of you would get a stimulus check. So I had the honor of writing a perspective piece for pediatrics that was published just yesterday with two colleagues of mine just around this topic, around COVID-19 and children and immigrant families. And one thing that we have, that we said in this perspective piece is that COVID-19 does not discriminate based on immigration status, and neither should the measures to lessen the impact of this pandemic. So in that sense, like, what can we do? What can we as physicians, you as medical students do? I'll say first, you're already at the front lines doing this. I recognize that you're not doing clinical time right now, but this resource database that you all have created is just phenomenal. And I think has been helpful for a lot of us as we're looking for resources for our families. So these are the things that we can do. You are doing that right now. We're also sharing multilingual information with families, offering resources for families to cope with emotional distress related to the pandemic. I know in our clinic, we are working on legal resources for families. I believe Elaine Wang is on the WebEx right now. She and other students have been phenomenal in helping us with our legal screening of families as well. And then on the broader sense, hospitals and health systems can increase the capacity for telehealth, allowing for multiple languages, making sure that there are multiple team members to help with these social determinants of health around employment and nutrition and housing and other programs. And then policymakers and health entities, can encourage states to provide Medicaid to all individuals, at least as it relates to COVID-19 testing and treatment, regardless of their immigration status. You all talked with Dr. Lichtenstein around data being stratified. It's hard to address inequities without having the data. So there are bills, and the AAP, the AMA, other organizations have been asking for this data from the federal government and from states. And then resuming these humanitarian protections at the border for unaccompanied children and family units is key to reducing the spread of the virus. So I'll stop there, and I'm happy to take any questions. Thank you for listening.
Thank you for a great presentation, Dr. Falusi. There is a question about any unique needs or issues among those in detention facilities specifically.
Mm-hmm. Yeah, so the most acute issue is the density. So that you have such a close, it's hard to do social distancing in a detention facility that is crammed. And even if that is the case, then you would hope that there is adequate and really robust testing and monitoring of the population, which is not happening. It's not only is it not happening, we don't even know how badly the virus is spreading because ICE is not releasing that data very quickly, or people are concerned about the integrity of the data that is being shared. So it's on multiple levels, I think, just on that public health kind of, are we practicing social distancing, to are we at least testing and monitoring and isolating people? And many organizations have actually called for the release of individuals from detention, so that they can actually be in communities as they await their trial, because many of them are applying for asylum, so there is a legal case that's pending. People can be kind of tracked and communicated with as their case goes through the system. And historically we've done that, but more recently we've actually just been detaining folks. So thinking about ways to actually allow people to practice social distancing, allowing them to be in a community rather than in a tightly packed detention center is one of the recommendations from multiple medical organizations.
Right, so similar issues as Dr. Kendick mentioned with incarcerated populations, et cetera, some of the challenges there. And another question about the family transmission that, in China, some of the early literature suggested family transmission was a primary source of disease dissemination, where they were seeing family clusters. Is that something we're seeing among immigrants given the multi-generational family setting that you mentioned?
Yeah, I think that's a great question. I think one, it's hard to say definitively because we don't have great data yet. I personally feel like we've been living in this COVID world for about 10 years now, but it's really only been about 2 months in this area. And in the United States, maybe since January or so, February, in terms of it really being on people's radar to think about data. I think over time we'll know more specifically, but anecdotally, I would say absolutely. The families that I saw yesterday was not the first that I'd seen with multiple generations or more than one family in one household potentially being exposed. So we're definitely seeing that, and then trying to be really creative with families about how to do isolation in their homes. So the family that I mentioned yesterday, they actually a different family that had a child who tested positive, the teenager who lives with her grandparents, and they actually all share a room. So her grandmother said that what they'll do is let her have the room. They'll move their bed out into the hallway, and so she can do all her schooling and eating and everything in the room and be isolated. And they'll wear gloves, and masks and that sort of thing, which is so hard in a one-bedroom apartment. But trying to figure out with families how they can protect themselves, these grandparents who are over 60, how to protect themselves in this sort of setting. I think spending the time and kind of walking them through these options helps families. We also have a social worker in our clinic who will be reaching out to families who tested positive to see what additional supports that they need. So as much as we need the data, and as terrible as the situation really does seem, I'm thankful that at least in some settings, we have some ways to try to mitigate, if not the public health impact, at least the emotional impact of this on families.
Thank you for that. And another question about perhaps expanding on some of the discussion that you began regarding barriers to seeking care. You mentioned it in the context to testing. Would you expand a little bit on the discussion related to some of the barriers the immigrant populations face in seeking care and testing, particularly in COVID-19?
Sure. So with testing, I think we're doing a better job with testing, but overall, there just are not enough tests or enough materials for the test. So and even less so in areas that have a large populations of people living in poverty. With immigrant populations as well, I mentioned lack of health insurance. So Dr. Lichtenstein described that there are these wonderful pop-up testing centers now that you need, right, an order from your primary care physician. You need to be able to get to these places. They're not always in the neighborhoods where people who lack access actually live. So I think we can do a better job with making those areas, putting more of these testing centers in those hard hit neighborhoods. And then also, I mentioned there is federal funding now through Medicaid for anyone who qualifies for Medicaid to be able to get testing for COVID-19. But when, 1 out of every 5 kids in the United States who is a lawfully present immigrant child does not qualify for insurance, then there are huge populations that are not going to be able to afford getting tested. I think we are doing a pretty good job of getting information out, at least in English and Spanish, but we know that those aren't the only languages of people who are being affected. We have large Amharic speaking populations and other languages, even in our region, that we could probably do a better job of getting the information out about where to get tested and how to get tested. So thinking about people with limited English proficiency and trying to be a little more deliberate about ensuring that we get the information out. So I think it's on multiple levels. It's insurance access, it's physical access, getting to testing, it's the quality of our cultural competency in getting the information out to families that need it.
Thank you for that. And you mentioned a bit of a chilling effect in terms of families and broader populations opting out of some of the resources and programs that they might be eligible for, such as WIC, et cetera. Are we seeing any impact? I know you talked about in theory, or potential impact of that, but are we actually seeing any of it here in locally or perhaps in broader context?
Yeah, I think it's the data on that also is very hard to capture because it involves kind of qualitative, asking families about the reasons why they may not be accessing services. But certain states have definitely seen a drop in their WIC utilization, specifically in Latinx families. And that is not correlated with an improvement in income or socioeconomic status. So sometimes people will say, oh, sure, people are using WIC less often because they're able to afford to not use WIC, so they're not using these federal programs as much. But actually, that doesn't bear out in some of the data that some of the state WIC agencies have released. There's also been a drop in SNAP utilization, particularly in Latinx communities, also not correlating with improvements in income. There have been smaller qualitative studies where families have mentioned public charge, if not using the actual term, at least mentioning that they're worried about the federal government immigration response if they utilize these programs as well. So there's like state level data. There are sort of like my and my colleagues' anecdotal data, but then also some research that's been done with families looking at those issues as well. I don't have new data since the pandemic started, but I know that people are starting to look at that to kind of tease out, whether we're seeing, as we see an increase in people accessing things like unemployment benefits and WIC and SNAP as they're unfortunately losing their incomes, are we seeing the same increase in immigrant families? And if not, you do have to wonder if some of that is from fear of accessing these programs.
Well, all very important questions and information. We greatly appreciate your presentation and sharing your time and your expertise and your passion with us as well. And with that, we will begin to transition to our presentation with Dr. Catherine Crossland to discuss COVID-19 in homeless populations. Dr. Crossland.
How are you? Well, I guess I can't ask how you all are doing. So I am trying to figure out a little bit of my computer stuff, so bear with me. Should I be on, do you guys want me to be on video? Would that be helpful?
I think whatever you're most comfortable with would be wonderful. We can hear you just fine. And if you do video, we'll go with that as well.
Perfect. Okay. Yay. Okay. So I'm here now, and as long as you can hear me okay, I don't have to worry about calling in. So I guess I just want to take some time to talk about what we've been doing for folks on the homelessness side of things. And then if anybody has questions, please chime in. I assume there's a place for participants to ask questions. So just a quick introduction. My name is Catherine Crossland, and I am a physician working with Unity Healthcare. I've been the medical director for our homeless outreach sites for about 9 years, and that includes all of our clinics that are meant to serve people with homelessness in our shelter-based clinics, all except the CCNV clinic, which has had its own medical director, as well as our clinics that are based in day centers, shower programs, meal programs, the street medicine program, et cetera. So that's sort of my on-the-ground clinical experience as well as management of those sites. Over the past few years, I have been working more closely with the city through the Interagency Council on Homelessness. I'm Unity Healthcare's organizational representative to the Interagency Council and have been trying to get a little bit more involved in sort of policy and sort of systems level changes while continuing to work in all of the different sites where we are serving people experiencing homelessness. So having both a little bit more of a kind of city-facing policy advocacy role as well as clinical. And then when this whole coronavirus erupted, I was working very closely with the Department of Human Services about, what their response should be. And, I think that DC Health has had their hands full with sort of the whole city, and Department of Human Services has been tasked essentially with trying to figure out how to address this public health crisis, really, as it exists among people experiencing homelessness. So I was working with them to try to figure out what the policy strategy should be in terms of having, what we should be telling shelter staff, what we should be telling shelter residents in terms of trying to prevent the spread of this. And it's, as you all know, this has been evolving from the beginning. And at first we were focusing on hygiene and hand washing and covering your cough with your elbow, and we were only giving out masks to people with a cough. Now, obviously, we're all wearing masks. Social distancing is being prioritized, although it has incredible limitations when you're talking about these massive shelters with dorm-style living. So, for example, at 801 East Shelter, each room houses 60 individuals. So there are 30 bunk beds lined up in rows. So 10 rows each, 3 rows of 10 bunk beds. And so those people are, coughing and touching the same surfaces in the bathrooms, touching the same surfaces in the common areas, the handles, the door handles, all that kind of stuff. So that's really, really challenging in these settings. And so as we were hearing the spread of COVID in these dorms and across the shelter system, we were trying to plan actively as to how we were going to manage this should there be outbreaks, which we all worried and suspected there would be. So the first thing that everybody was thinking about was, well, if somebody develops symptoms and they need to be tested, rather than sending them back to the shelter to await their test results, we need a safe place for them to quarantine where they're not going to be, inadvertently spreading this while they wait for their test results to come back. And so the concept of having safe places for folks to quarantine became a really high priority. And so the Department of Human Services contracted with several hotels throughout the city where we could send folks to quarantine if they rose to the level of suspicion to be tested in the first place. And this could be whether they were going to be tested at GW Hospital, emergency department, or whether or not they were going to be tested at Unity clinics, for example. So people who are going for quarantine while they await their test results go to these hotels. We also are very lucky to have partnerships with the GW strike team that has partnered with DC Health. And so essentially, instead of testing somebody at Unity and sending them to the hotel to get quarantined, or testing somebody in an emergency department and sending them to these hotels to get quarantined, we have the ability to have shelter staff and outreach workers who do street outreach to just refer somebody who has symptoms directly to these hotels, where we then, Unity Healthcare, is on site providing care. And I can tell you a little bit about what that looks like. And then we order a test for folks when they arrive through the GW strike team. So that's an incredible thing. So people with symptoms who've either been tested off-site or who need to be tested on-site can come to these isolation and quarantine sites. The other population is people who were tested in the hospital and were diagnosed with coronavirus, and they need a place to isolate safely so that they don't spread it. And so those folks are being discharged from the hospital to these hotels, the isolation and quarantine sites. We refer to them as ISAQ for short, ISAQ. And then the third population, now that we have known cases in the shelters, is folks who are close contacts of a known patient with coronavirus. So somebody who was sleeping in the bed next to yours. Some would say everybody in that whole dorm should be sent, but we don't have the capacity to take on 60 people every time one person in that dorm is testing positive. So really what we're doing is contact tracing. We're finding out, well, who is this person who's positive, what bed were they in, and who was sleeping essentially within 6 feet of that person. And so those folks are identified as close contacts who are then referred to the isolation and quarantine sites to be quarantined for 14 days. Unity Healthcare is on site at all of these quarantine sites. We now have 4 hotels where we're operating. Unity has both medical doctors and nurse practitioners, so medical providers, but the Department of Human Services has contracted with a staffing agency to provide nursing care as well, because as you might imagine, the needs for medical resources are tremendous. And we have been tasked with both admitting the folks to these sites, taking a good history to find out, are you here for known diagnosed COVID? Are you here because you have symptoms and you need to be tested? Or are you here because you're a close contact and you're here for quarantine? Do you take medications that we should know about? Are you missing any medications? You know, we have to do all of that kind of care to make sure that sort of people's chronic medical problems that they already have don't fall by the wayside. And we've come up with systems to get people the medications that they need at these sites. We have patients who are on dialysis, who we need to arrange for them to get to and from dialysis while they're either positive or while they're in quarantine or awaiting test results. And so we have to do that in a safe way that not only protects people who are transporting them, but the people at the dialysis center, et cetera. And then so we're doing the intake, but then we're also doing daily wellness checks on every single person. So anybody who comes in with symptoms, we're doing wellness checks to make sure that their symptoms aren't getting worse, that they don't need a higher level of care. Anybody who comes in for quarantine, we're doing daily wellness checks to make sure that they aren't developing symptoms and need testing. So it's a complicated process for the isolation and quarantine sites, and then we're discharging people essentially based on CDC criteria and DC Health criteria, whether they've tested positive, negative, or quarantine and never developed symptoms. So that's the isolation and quarantine response that the Department of Human Services has come up with for people experiencing homelessness. Other side of things, we have had something that we thought about very, very early on was, I'm just gonna silence this phone. One thing that we thought about very, very early on was, you know, we're thinking about a response strategy for anybody who tests, who has symptoms and needs to be tested. But what do we do about all of these really high risk folks that the CDC is saying should be sheltering in place and self-quarantining to prevent the development of this, or to prevent the exposure of this illness? And so I actually drafted a proposal and sent to the Department of Human Services in early March, essentially saying that I thought we should proactively create a space for these really highly vulnerable folks to quarantine. And so, in addition to the 4 isolation and quarantine sites, we have a hotel that's specifically for our highest risk patient population, and that includes people over 80, and there are 6 people over 80 in our shelter system, unfortunately. People over 70 with certain medical conditions, and then people under 70 with certain severe medical conditions, including things like active cancer treatment, undergoing therapy, end-stage renal disease. So people who are not only at a high risk for complications should they themselves develop it, but people who we think of as high touch, who, if they were to develop coronavirus, would put a lot of other people at risk in the course of their daily life, like the people who are going to dialysis every day. So dialysis automatically qualifies somebody to get into this high risk hotel. Unfortunately, right now we only have one of them, and it's 125 rooms, and there are way more vulnerable people in our shelter or our homeless population at present than that can accommodate. We're hoping to get another hotel online soon. And again, these are folks who we hope have not yet been exposed, but unfortunately, we've had a couple of people there who have already tested positive and have had to go to the isolation sites. So that's sort of from the city's perspective, what we are doing to kind of care for people experiencing homelessness in this pandemic. The other side of that is, you know, what's happening to people who are still in the shelters, who haven't come to one of the isolation and quarantine sites. The medical services that Unity Healthcare provides to people experiencing homelessness, similar to every other community health center, we have tried to minimize, I should say, maximize our telehealth visits. So, so we are rescheduling routine visits that can wait. We are doing telehealth for routine visits that don't require a physical exam, like medication refills, things like that. And for people who are sick, if they are sick and they're at home, we are asking them to sort of try to stay at home and self-quarantine / isolate if they're not getting tested. But for the folks in the shelters, obviously, anybody who develops symptoms, they're going immediately to these isolation quarantine sites. Because we've had to divert so many of our medical resources to these isolation and quarantine sites, we've essentially closed every single one of our clinics that are based in the shelters, except for the CCNV clinic. So that's been a real challenge. We're trying to do telehealth at the other sites. We, for a while, were doing outpatient screening. We were doing COVID screenings at all of the shelters, where we would bring a team and we would try to evaluate the entire shelter population for symptoms, and then referring as we could to the isolation and quarantine sites. and then providing some non-COVID related medical care on the side. So that's a big preoccupation of ours, is what's happening to all of our patients where we now don't have kind of the traditional on-site medical services. And then I would just say the final piece is this question of universal testing. And we've now have a certain shelters where there have been little outbreaks. And so, for example, the Department of Human Services is embarking on a project to test every single person staying at the New York Avenue shelter, including all staff. And so that's going to be a situation where everybody gets tested, and unfortunately, we don't have the capacity at the ISAC sites to quarantine every single person while they're awaiting those test results. But because everybody was tested for one point in time, they'll all wait for the 24 to 48 hours that the test results come back. And then once the test results come back, anybody who's positive, well, it sort of remains to be determined. If 90% come back positive, then they'll probably cohort and group isolate. If 10% come back positive, then they'll probably be sent to the isolation and quarantine sites to isolate and be removed from that cohort. So it's sort of this is population health down and dirty. We're trying to minimize risk to the whole group. So like I said, if say 90% is positive, then maybe we remove the 10% that aren't positive so that they can quarantine in a safer space in a hotel room. So anyway, that's I've gone on for like 20 minutes. I don't know how long I'm supposed to be talking, but I'd love to take questions if anybody has any questions and anything I didn't touch on.
Thank you so much for that wonderful presentation and for taking time out of your busy schedule to share some of your important work with us. There is a question about some of the special needs for those who are unsheltered. If there's some work, I think you mentioned the outreach workers, and if you would discuss a little bit of some of that work.
Yep, absolutely. So Unity Healthcare has partnered with outreach workers all across the city. We have a robust street medicine program. So in the beginning, before we had so many ISAC sites, I mean, right now we have probably when and if we're completely full, it's between it's probably 800 people that we're talking about that have to be seen every single day, or not seen, but we're doing telephone visits as much as possible to get through the census and then seeing people as needed. Anyway, so when we were not so busy with isolation and quarantine sites, we were still doing our street medicine rounds with our partners from Pathways to Housing, Miriam's Kitchen, etc. The street rounds have significantly decreased. So I know that Miriam's Kitchen street rounds has, I think, is on pause. Pathways to Housing, to my knowledge, is maybe one of the only outreach organizations in town that's still operating. I think HIPS maybe as well, and maybe one or two other sort of small ones. But they too, anytime they identify somebody who has symptoms and need to be tested, they can call the DHS hotline and get somebody picked up and taken over to one of the isolation and quarantine sites to be tested. So we do have quite a number of people who were referred that way from the outreach, the street outreach side of things. It's interesting because in some ways the risks of spread to this population on the street is less because there's more physical distance. There's the opportunity potentially to sort of have that social distancing. On the other side, access to clean, water, washing your hands with soap and water, access to hand sanitizer, all of those kinds of things are more challenging if you're outside. And especially because downtown has really shut down in so many ways, that the bathrooms that people have grown used to using, not only to go to the bathroom, but to, wash their hands and things like that, are just not accessible. And so I think that that has been a huge problem. It's also been a huge problem just in terms of like getting basic needs met, food, shelter, like being able to go inside somewhere when it's cold and rainy, as it's been these past few weeks, because so many stores and restaurants where people used to access, the libraries are all closed. I mean, all these places, all the day centers, the city's day centers for people experiencing homelessness, all closed early on, which I thought was actually a very good move in some ways, because the shelters were staying open 24/7, and people weren't being pushed out in the morning and made to go across town on a shuttle and be in another room with a bunch of other people. The sort of risk for spread seemed kind of infinitely more by kicking people out of the shelter. But on the flip side, people who are in the street, who relied on those services for meals and showers and medical care, now are really left in a desert in so many ways.
That's very helpful. Thank you very much. And there are a few questions about whether you have any data or any sense of what the incidence among the homeless population in general locally is for COVID-19, whether we have any stats on that.
You know what? We are working on that. I don't know that I can give you data right this second. Data management has been a huge issue, and trying to keep up with the numbers. We can, I think that right now we're not testing universally, so we're only testing people who are symptomatic. What I can tell you is that there are people who come in who are symptomatic who test positive, as we would expect. There are people who come in who test positive who are negative. I'm sorry, people who come in with symptoms who test negative. And for those, honestly, sometimes we worry that maybe that's a false negative. So I think we're working with imperfect data in terms of, we have test results for people, but I think it's once we have a chance to kind of catch our breath and sort of take a bigger step back and look at the data, I think that'll be very interesting to see. But I think, for example, like at New York Avenue, they are, because they're going to do universal testing, I think we'll have a much better picture, similar to Boston when they tested everybody at Pine Street Inn, what the actual sort of incidence looks like, right? Because right now we're only testing people with symptoms, except those rare times when somebody comes in for quarantine and accidentally gets put on the to be tested list. And a lot of those people end up being positive. So I think we actually have no true idea of how many people in the shelter actually are infected with COVID. That was probably not a great answer. I don't have numbers for you. I wish I could say like 10%, 15%. I could go run our numbers and say, of the people who've come through the isolation and quarantine site with symptoms, this many have tested positive. Without symptoms, they're not supposed to be tested, but some of them were and were positive. But that, to me, in some ways, is just the tip of the iceberg. I'm hoping we move toward universal testing for all of these vulnerable populations. And I think that once this happens at New York Avenue on Friday, we will potentially be able to make a very strong case for doing that across the homeless services system, both for sheltered and unsheltered people experiencing homelessness.
That's, sounds like incomplete and imperfect data is one of many challenges that you and many of us face throughout the COVID-19 epidemic. And I think for our final question, we have one that's a little bit more the nitty-gritty of funding. That is, where the funding for the isolation and quarantine sites, specifically hotels, et cetera, comes from, and is there potential for reimbursement, et cetera?
That's a great question. So the short answer is emergency funds, right? So the Department of Human Services, as soon as Mayor Bowser declared a state of emergency, we have access to federal funds, and the Department of Human Services is using these funds in part to fund this project. There was some discussion about who should be staffing this. Should this be run by the Department of Health, because this is a public health crisis? But the Department of Health only has a handful of physicians that essentially run the public STD clinic. So Unity Healthcare was sort of the natural partner, because we provide medical care to the largest percentage of people experiencing homelessness in the city. And so they reached out to us, and Unity was very concerned about not having the staffing. So the Department of Human Services said, well, fine, we'll find staff for you. We will contract with Motier, which is a staffing agency, to get nurses. So it's been this very elaborate process of having a three-way contract between Unity Healthcare, Department of Human Services, and the staffing agency. And the funds are all coming from the Department of Human Services emergency management funds for this. And then Unity is trying to bill for every visit, every encounter that we see. All of the nurses are in the process of getting access to our electronic medical record, but it's very slow going, as you all might imagine. And then ultimately, I think a nursing visit ends up getting about $17 per visit, whereas a provider visit is much more lucrative, getting upwards of $150 per visit. So we are definitely trying to maximize our provider visits, because, like I said, we have to make contact with every single person on site every single day. It's just a matter of how many of those can be a provider visit versus a nurse visit. Does that answer the question?
It does indeed. And from all of us, we wish you and your colleagues health as you continue with this. And again, great thanks for your presentation today. And with that, we'd like to thank Dr. Crossland and all of our great panelists for their presentations today in this symposium. Please look at the Clinical Public Health website for this recording and the recording of past events. We look forward to ongoing discussion about marginalized populations and health disparities, with an eye toward promoting health equity in our next symposium. And with that, we conclude our symposium for today. Thank you all.
Thank you.